Hello, and you're very welcome to this first lecture, which deals with heart failure in the role of uh, introducing you to the concepts and an overall introduction to heart failure and the pathophysiology. You'll see on the top left-hand corner of the slide is a very important disclaimer. This is primarily an educational tool. It is not meant to be over-interpreted, it's not meant to affect clinical decision-making, and it's aimed at medical students, but all are welcome to partake. We're meant to have learning objectives for all our talks, so after this lecture I hope you'll be able to define heart failure and outline the signs and symptoms of heart failure. We'll give you an idea of the burden of disease, and we'll spend a fair amount of time trying to explain the pathophysiology of heart failure and essentially how homeostatic mechanisms, while initially helpful, can become counterproductive. This is a chest x-ray of a patient suffering from heart failure. What you might notice here is that there is a cardiomegaly, an enlarged heart. You'll see a cardiac implanted device here, in this case a cardiac defibrillator, to reduce the risk of sudden cardiac death. You'll see the lung fields are very puffy and contain fluid. And this would be a fairly typical feature in someone with advanced heart failure. It's important to begin with the definition of heart failure. Heart failure can be defined as a complex clinical syndrome that occurs from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. What this means basically is that patients with heart failure on treatment may be asymptomatic, but in patients with symptoms they describe impaired effort tolerance, fatigue, fluid retention, and unfortunately death. Death can either come quickly or suddenly depending on the state of the patient, the extent of the disease, and other clinical presentations which we'll talk about later. Big hearts are a big problem. The advantage of this is because it's such a common disease entity, there's been an enormous amount of research and there's a lot of randomized controlled trials and evidence-based medicine to guide our treatment for patients, particularly with systolic heart failure. Thus, it is a very commonly encountered medical condition, probably the most common medical diagnosis requiring admission, particularly in those over the age of 65. There's a massive population of patients known to have heart failure in the United States alone. It's estimated approximately 5 million people suffer from heart failure, and there are up to 4 or even 500,000 new cases per year diagnosed. Just to put it in perspective, you'll hear by my accent that I'm Irish, and the population of Ireland, at least the Republic of Ireland, represents the population of heart failure in the United States of America as we speak. Terminology, as always, causes a lot of confusion. And as we recall, heart failure is a syndrome, a clinical entity with signs and symptoms. This is different from cardiomyopathy, which is essentially, if it's primary, it's a pathological condition or primary disease of the heart muscle, which we'll briefly discuss, and there'll be other lectures on this. Primary cardiomyopathy is different from secondary cardiomyopathy. We term as secondary cardiomyopathy is where the heart muscle is diseased because of an underlying condition, the most common being ischemic heart disease, but also including hypertensive and valvular and even toxic conditions. What's very important to say is that you can have heart failure without cardiomyopathy, and you can have cardiomyopathy without heart failure. In other words, not all heart failure is due to failure of the heart. So we typically describe heart failure when there's reduced cardiac output, but heart failure can also occur in 3 specific conditions where the heart is actually structurally intact, at least at the beginning of the condition, but with time can become dysfunctional. High output cardiac failure occurs in severe anemia, hyperthyroidism or thyrotoxicosis, and in significant or large arteriovenous malformations. Patients with heart failure present in a variety of ways. A lot of patients can become asymptomatic having been treated. Many patients present with acute decompensated heart failure to the emergency room or hospital setting. And many patients live with chronic heart failure with chronic debilitating symptoms of varying severity, which we'll talk about later. Unfortunately, death is a common feature and seen in patients at all stages of heart failure, and death can occur in the asymptomatic patient with previous episodes of heart failure. Death can occur in the acute decompensated heart failure patient, and death can occur in patients with chronic heart failure symptoms. The pathophysiology of heart failure is extraordinarily complex. A simplistic approach would say that the primary problem is with the heart, which is true, but many of the effects of heart failure are due to the systemic or homeostatic responses of the organism to heart failure, and we'll tease these out in a few moments. Coming back to the heart for a moment again, we accept that the primary problem is with pumping. If there's systolic heart failure, in other words, the ability of the heart to eject blood. So in patients with poor ejection fraction, the amount of blood ejected is reduced, therefore the cardiac output is reduced, in severe cases at rest, but in many cases it may be normal or low normal at rest, but fails to augment with increased demands, for example during exercise. In diastolic heart failure or diastolic dysfunction, the systolic function may or may not be normal, but what's important is that there's impairment of the ventricles to allow blood into the heart, and this is called diastolic dysfunction. And often you'll have combined systolic and diastolic dysfunction. Indeed, nearly all systolic function is accompanied by a significant diastolic dysfunction. On the other hand, many patients appear to have almost pure diastolic dysfunction, where the systolic or pumping function of the heart appears to be maintained. The reason these distinctions are important is that the majority of evidence-based treatment for heart failure relates to patients with systolic dysfunction, in other words, those with impaired left ventricular ejection fraction, and we have very little for patients with pure diastolic heart failure. This is a very busy slide, and I'm going to break it down a little bit further. But essentially, in thinking about the pathophysiological mechanisms important in the heart failure syndrome, we can divide it into problems with the heart, which we've briefly discussed, but we're going to dig into a little bit more. We can describe what are called, I like to call, evil humours, circulating agents, which effectively result in many of the signs and symptoms of the heart failure syndrome. And then other factors, some of which are modifiable and some of which aren't. Let's break these down a little bit. The primary problem, as I said, is with the heart. And we can look at the heart in many ways. We can talk about structural abnormalities within the heart. And in the micro level, these include problems with the myocyte, or the heart muscle cell, which can be hypertrophied, fibrosed, necrosed, or there could be active apoptosis in many pathophysiological conditions. At the cell level, there's also evidence of dysfunction of the beta-adrenoreceptor and beta-adrenoreceptor coupling. We can see this on the macro level with chamber left ventricular and right ventricular chamber dilatation, which is a combination of remodeling, dilatation, change in shape, aneurysm formation, and replacement fibrosis. We can look at the structure of the coronary arteries, which can become inflamed or obstructed, and indeed coronary artery disease remains the most important structural abnormality resulting in the heart failure syndrome. Functional deficits are also seen, where because of this remodeling, we see functional mitral or tricuspid regurgitation because of enlargement of the ventricular cavities and failure of coaptation. Ongoing ischemia, which can result in further necrosis and fibrosis, or indeed ischemia can result in hibernation, in other words, heart muscle cells that are actually viable but fail to achieve adequate oxygen or blood supply to allow adequate contractility. Arrhythmias can be superimposed on cardiac abnormalities to exacerbate the condition, or alternatively, on occasion, in a condition called the cardiomyopathy of arrhythmia or the cardiomyopathy of tachycardia, the arrhythmia itself is the primary process that drives the left ventricular systolic dysfunction. In this slide, we're looking at the evil humours, or the neuroendocrine system. These can be broken down into various subsections, including the renin-angiotensin system, the sympathetic nervous system, antidiuretic hormone or vasopressin, natriuretic peptides, which are peptides released from the heart. The most important one is known to be brain-type natriuretic peptide, or BNP, cytokines, vasodilators including bradykinins, and then matrix metalloproteinases, the actual importance of which is somewhat debated. The importance of these agents is that they are released in various amounts in various patients at various times of the heart failure syndrome. And although the overall aim is to improve myocardial function and improve the organism's response to the heart failure syndrome, a lot of overactivity within these areas causes the fluid retention, salt and water retention, and the many other symptoms and signs seen in the heart failure syndrome. The milieu in which this all occurs is terribly important. Many other factors will modify the heart failure response of the organism. Age is an important driver. Older patients tend to do worse. Coexisting conditions, some of which predispose to heart failure in the first instance, but also modulate the response to the heart failure syndrome, include concomitant diabetes, hypertension, kidney disease, coronary disease, anemia, obesity, sleep apnea, and depression. It's important to look for all of these conditions in patients with heart failure because optimization of treatment in each of these areas will improve the overall response of the patient to the heart failure syndrome. Environmental factors are terribly important, and they include alcohol, tobacco, overall toxic drugs of abuse, including cocaine, and other agents that may worsen the heart failure syndrome, for example, the use of non-steroidal anti-inflammatory agents. So when you put it all together, this is what you have. You have a complex interplay of cardiac abnormalities, neurohormonal abnormalities, and other factors which result in the phenotypic expression of the heart failure syndrome. Salt and water homeostasis lie at the heart of the heart failure syndrome and are responsible for many of the signs and symptoms. Depressed left ventricular systolic function and reduced cardiac output in and of themselves, by reducing cardiac output, may cause some of the symptoms of heart failure: fatigability, poor effort tolerance. But why do we get edema? Well, it comes down to the response of the central nervous system vasomotor response to reduced cardiac output. This diagram is simplified and by no means exhaustive, but essentially, when there's reduced cardiac output sensed by the central nervous system vasomotor centre, it results in increased sympathetic nervous system activity, increased renin secretion, and of course then increase in angiotensin II levels. Renin, as you know, is produced by the kidneys in response to increased sympathetic nervous system activity, particularly circulating noradrenaline levels, and by direct response to sympathetic innervation of the kidney itself. Renin then drives the secretion of angiotensin I from the liver, which is converted in the lungs to angiotensin II. Angiotensin II is a powerful vasoconstrictor. The result of this vasoconstriction is reduced renal blood flow and the secondary renal and adrenal effects, which are summarised here. The CNS itself also, through sensing reduced cardiac output, directly increases ADH secretion from the posterior pituitary. This is also known as vasopressin, and vasopressin itself is a powerful vasoconstrictor and causes increased free water absorption. In other words, heart failure is perceived as a state of hypovolemia, and all of these physiologic responses are seen in patients in acute states of dehydration. However, in the long run, while initially helpful, these responses become counterproductive. And what we see is salt retention, water retention, and circulatory shift. Edema thus develops, for example, in the peripheries where it's felt as pitting edema, but acute fluid retention can result in deposition of fluid within the interstitium of the lungs and chronically even with pleural effusions. Thus many of the symptoms and the signs of the heart failure syndrome are explicable in terms of the neurohormonal or salt and water retaining response to reduce cardiac output. The increased afterload by the vasoconstrictors, in other words, the squeezing down of the blood vessels at the level of the resistance arterioles, means it's harder for blood to be ejected from the heart, and this further reduces cardiac output. The reason that this is important to understand is that treatment of the neurohormonal milieu is essential in treating the heart failure symptom cluster. So we'll come to three questions then. Firstly, what causes heart failure? Secondly, what does the heart failure syndrome cause? And thirdly, what happens to these patients with heart failure? We'll turn to the first question first, which is what causes heart failure? Well, pretty much anything that will upset the heart. So if you have any problems with the arteries of the heart, with the muscle of the heart, with the valves of the heart, or with the rhythm of the heart, that can cause the heart to fail. Thus we come up with a very simple but not exhaustive list of causes of heart failure. These include coronary artery disease, hypertension, primary heart muscle disease, toxic causes, valvular heart disease, arrhythmias, high output cardiac failure, cor pulmonale, which is heart failure related to primary respiratory disease, and of course congenital heart disease. Coronary heart disease remains the leading cause of heart failure, and as you can see in the slide here, this is an explanted heart showing extensive myocardial fibrosis where the muscle has been replaced by scar tissue. And it's a sobering thought to know that 22% of men and 46% of women will have significant heart failure symptoms within the following 6 years following myocardial infarction. Why does this happen? Well, left ventricular systolic function can severely deteriorate if there's acute major myocardial infarction, and this is called acute shock in the setting of acute myocardial infarction. This is relatively rare as a cause of chronic heart failure because many patients who present with acute shock will die and won't survive long enough to develop the full heart failure syndrome. The majority of patients with ischemic heart disease who have heart failure have suffered a thing called left ventricular remodeling, which is shown in this diagram here. On the left-hand side, we see a schema of a normal left ventricle. Following myocardial infarction, there's an area of the myocardium which becomes infarcted and is typically replaced by scar tissue. The size of the scar will to a large extent determine the risk of developing heart failure. Patients at this stage will often be asymptomatic because the other myocardial segments can recruit and function normally and achieve adequate cardiac output to render the patient asymptomatic. With time, however, a significant patient population will develop progressive left ventricular remodeling. And what happens here is that the left ventricle dilates, becomes enlarged, becomes more spherical in shape, and myocardial segments that were not initially involved in the myocardial infarction become dysfunctional, thinned, and replaced by fibrosis. The concept of left ventricular remodeling comes up time and time again in patients with heart failure, and it's important to know that it's not entirely confined to ischemic heart disease. Indeed, left ventricular enlargement, the development of a spherical heart muscle, and replacement of muscle cells with fibrosis occurs as the final common pathway in a variety of cardiac insults. Hypertension remains a very important cause of heart failure and is probably among the commonest causes of heart failure in elderly females. What happens in hypertension is you get left ventricular hypertrophy, thickening of the heart muscle, and eventual fibrosis to replace the heart muscle. The initial abnormalities seen in hypertension would be relaxation abnormalities, in other words, diastolic dysfunction. However, later, particularly if untreated, hypertensive heart disease results in significant systolic dysfunction. Valvular cardiomyopathies, which are spoken about in another lecture, result in left ventricular systolic dysfunction if there's either volume or pressure overload on the heart for a very long period of time. Cardiomyopathy causes a lot of confusion related to the terminology. As I mentioned earlier, primary cardiomyopathies are essentially primary diseases of the heart muscle, and these can be classified as dilated, where there's increased heart size, dilatation, and a change in the shape of the heart; hypertrophic, a typically genetic condition where there's thickening of the heart muscle, and virtually by definition in the absence of hypertension; a rare condition called arrhythmogenic right ventricular cardiomyopathy, where the right ventricle is primarily affected, and this is associated with arrhythmias, particularly in the early course of the disease; and finally then a rare enough condition called restrictive cardiomyopathy. Cardiomyopathies can often be genetic or familial. They are often said to be post-viral. Peripartum cardiomyopathy is well described, and this is heart muscle failure presenting in the last trimester of pregnancy or in the early postpartum period. Stress-induced cardiomyopathy is an increasingly recognized phenomenon. This is also called Takotsubo's disease, where an extremely stressful situation, for example a major operation, receiving very bad news, causes transient and rarely sustained regional wall motion abnormalities which don't fit in with any coronary distribution. Toxic cardiomyopathies, including alcohol and chemotherapy, are included here as some patients' susceptibility to these agents appears to be genetically determined. But at the end of the day, we have to be pragmatic about the heart failure syndrome and the etiology. And the major division really is between ischemic versus non-ischemic cardiomyopathy, and between systolic and diastolic heart failure. Beyond that, the treatment, which we'll deal with in another lecture, essentially means withdrawing the offending agent. For example, if someone is taking alcohol, they need to stop alcohol. If someone's taking cocaine, they need to stop cocaine, etc. If it's felt to be idiopathic, it may be familial or genetic, and hence screening issues arise. The treatment is often the same, and as I mentioned earlier, the treatment of the neurohormonal cascade remains the cornerstone of treatment of patients with heart failure. So the question we're going to ask ourselves is, what does the heart failure syndrome cause? And here I've listed the symptoms and signs of the heart failure syndrome, which you could pretty much make up based on the earlier pathophysiologic discussion. Breathlessness, chest pain, edema, fatigue, early satiety, palpitations, and syncope can all be the symptoms of the heart failure syndrome. The signs include tachycardia. Up to a third of patients will have atrial fibrillation during the course of their disease, so the pulse may be irregular. You may expect to see peripheral vasoconstriction, cold peripherals, low blood pressure, though this is not at all ubiquitous. If there's fluid accumulation, we'll see an elevation of the jugular venous pulsation. We may hear a third heart sound, valvular regurgitation, which is often functional, crepitation, squeeze, or effusions in the lungs. If there's fluid retention in the peritoneal cavity, we'll get ascites. We may get organomegaly due to back pressure, and we may get edema for all the reasons discussed previously. It's very useful, if not essential, to review the New York Heart Association functional classification of patients with heart failure. This is not the same as a dyspnea score, so not every patient will complain of breathlessness. For some patients, it'll be chest discomfort, it'll be palpitation or tiredness. It's very important to be able to classify patients from class 1 to class 4. So what happens to patients with heart failure? Well, this slide is rather depressing, but it represents the reality of heart failure for many of our patients. As you can see along the top line, we have no symptoms, mild symptoms, severe symptoms, and then advanced symptoms. This correlates with the previous slides, New York Heart Association functional classification of 1 to 4. This is the timeline here from diagnosis to death. Many patients will have dips in functional status whereby they'll deteriorate, whereby they'll develop fluid retention, reduced cardiac output exacerbations, and admission to the hospital, and then they restore to previous level of functioning. Most patients progress along this line and eventually will suffer from advanced heart failure, which will necessitate transplant, mechanical assist, or even palliative care towards the end. That said, a significant number of patients will have a very good quality of life. The population is so vast that it's very difficult to make generalizations. Including elderly patients who have comorbidities, the mortality may be up to 50% at 5 years. In this way, certain subgroups have worse prognosis than patients with metastatic cancer. The quality of life for many patients can be very, very poor, although this has improved with good heart failure disease management programs, which we'll deal with in another talk. Up until recently, there's been a very poor appreciation of the role of palliative care in heart failure, and this really is at odds with how we manage patients with advanced malignancies, where palliative care has really formed the backbone of a lot of advanced care. This is my last slide, and I'd just like to say that it's not all bad news, because through a combination of interventions, the prognosis for patients with heart failure has significantly improved, as indeed has the quality of life. Through implantable cardiac devices, we've improved both symptoms and longevity. Medications have improved symptoms and longevity. And with further uploads from this channel, hopefully you'll be able to understand a little bit more of the investigation, particularly the management of patients with heart failure. Bye for now. Please feel free to check out my further talks on Jim's cardiology lectures.